Hi, good afternoon, everyone. Thank you for joining us for the Telehealth Learning Collaborative. As a reminder, you likely just saw this meeting is being recorded and will be archived on the Adirondack Health Institute YouTube page. Nice to see everyone on the call. I'm Andrea Bonacci, Director of Population Health Programs with Adirondack Health Institute and overseeing the North Country Telehealth Partnership. So thank you for joining us today. I know we have some people still joining us, but I'm gonna just hop in to be mindful of everyone's time. Just a few things to go through before we get into our presentation. No telehealth policy updates. I checked in with DOH, OMH, OASAS, OPWDD, as well as CMS, and no regulatory policy updates to make note of. So just wanted to share that. And then I'll jump ahead. No updates from Fort Drum Regional Health Planning Organization right now. From Adirondack Health Institute, I'll just offer a couple of updates. The North Country Leadership Summit took place in Lake Placid in October. Thank you to those of you who were able to join us and participate. It was a really great event. The presentation slide decks are now available on the AHI Summit webpage. I will include that link in the chat, but it will also be included with the meeting notes. So you're welcome to visit that webpage and take a look at some of the slide decks that were shared during the summit. And then just one other update that I wanted to provide. The North Country Telehealth Partnership was awarded funding through the New York State Connect All office for the Digital Equity Technical Assistance funding. So we will be utilizing that support to formalize the North Country Digital Inclusion Coalition, which some of you are familiar with and have participated in. So we're in the very early planning stages, more to come, but just wanted to share that update with everyone. So we're very excited to be able to further our digital equity efforts in the Adirondack region. So now I will hand it over to Chris Gauer. He is our presenter today, and he is with Vital Care Services, and he'll be presenting on some of their population health and telehealth initiatives. So Chris, I'll hand it over to you. I'm going to turn my camera off and I'll be monitoring the chat, and then once presentation is done, we'll move into QA, and then I'll hop back on for, to close things out and just give some final resources. Thank you.
Sounds good. Good afternoon, everyone. Thank you so much for taking time out of your busy day just to join me for a brief conversation on total population health management. I'm going to be sharing a little bit about some insights into the work that we've been doing for over a decade now, really trying to revolutionize the way that telehealth technology and services can help patients in the community. So just want to confirm everyone can see my screen. I have my screen here.
Yes, we
So the
can.
title of this is, thank you, is Utilizing Technology for Total Population Health Management, Clinical, Social, and Mental Health in Person-Centric Care. So my background is in business and marketing. Specifically, I volunteer as an EMT. We're located in Westchester County, New York, just to give you some background. I'm the co-founder, along with my brother, for Vital Care Services. And we've been very lucky to be in this industry for a while now. And we're very excited to share a little bit of some information with you. The agenda here that you see on the slide is the following. I just want to give a little recap of key trends, especially here in 2024 and beyond, as far as key trends in healthcare. The main topic of the presentation is on total population health management, really reaching all patients of various acuity levels, of various needs, various ages across the continuum. There's a couple of examples of tiered service models that we've explored, which I just want to introduce. And my hope in this presentation is that, especially in the QA area, or if you have different areas of expertise, just to kind of give you a flavor of what technology and specifically service models are emerging to help with patient care, whether it be clinical, social well-being, or mental health. I want to have one dedicated slide just relating to some of the technology and services that we do specifically. Common questions are related often to security and compliance, so I'll be sharing a very high level on that. And then as a clinician myself, I love this slide about case studies and real life examples, real practical, applicable, real life case stories that we've seen, which ultimately really drives us in our innovation, in our patient care. And then finally, what everyone talks about is where's the money? Reimbursement updates that we've seen from our own personal experience and where it's going as far as uh, reimbursements as it relates to Medicare specifically. So as the key trends move, the healthcare continues to move out of hospital as far as the traditional bed that is into the homes, providing with technology, being able to monitor and triage patients. As you see on the left side, acute care, very expensive. The specialty clinics and ICU, very expensive cost per day. But as you utilize technology or things more in the homes, it tends to get more cost effective, especially with the older adult population that continues to age every year, living longer. And along the way, of course, you have community care, assisted living, skilled nursing, et cetera, all the
Hi.
way up to
Well,
How
over
did I know
here.
we,
iPhone charger.
Yeah.
Running.
you have this?
Yeah.
Or I was gonna say I have a block if you need one.
Please make sure that you're muted if you're attending as a guest. Thank you.
So as we go here, this is an example of general statistics on these different levels of the total population. You see there's different three levels. There's the stay healthy, which is the majority of the general population, 75%. And then there's level two, which is, chronic living with chronic illnesses, and they have chronic disease management. These are your patients with hypertension, diabetes, combination thereof, COPD, CHF, et cetera. But at the most time, they do have a handle on it. They have a diagnosis, perhaps medication, perhaps they're trying to incorporate some lifestyle. And then you have the 5% or so of people, what we call level three, are trying to get healthy, trying to be able to stabilize. Perhaps they had an acute medical incident, such as a fall, which has led to ambulatory challenges, or a heart attack, or a stroke. Um, a lot of times, home care and post-hospitalization is really necessary to get healthy. So this is a nice little snapshot of different areas of the population and the percentage weight that typically is there. And specifically, which is kind of just a flavor of it, is what type of technology, because at the end of the day, as the saying goes, not one size fits all. So where, Fitbit and Apple Watches are great for really the top portion, which are trying to stay healthy and wellness and prevention, for someone that's trying to get healthy, they might need some more services and more technology at a more frequent basis. This slide is a kind of a nice summary of really something that we theorized about 13 years ago when we started our company, is to really have a tiered service model based off of the slide I just showed. And we have a very interesting model that's really grown because ever since we started together as a company, we really wanted to go after the full total population. And we've been very lucky, especially as we were formed in 2012, before the pandemic, before most people nowadays know what telehealth is. Perhaps most of you have done a telehealth virtual visit with your doctor at this point. We were really ahead of the time as it relates to these types of things. And we're really moving into a hybrid and virtual competent world on both the provider and patient side. So as you see on the left side, and I'm going to sprinkle in some real examples that we're doing here, for example, in Westchester County and the surrounding Northeast area. But you see on the left side, wellness and prevention care, community engagement, using some wearable technology, doing some health coaching and education, and really advising people to follow up with their PCP. A great example I can share of this one is here in Westchester County, for example. We have wonderful ethnic fairs, community-wide events that we do, for example, in the summer, as well as other community free events that the county provides for all ages. And at those situations, we don't necessarily need to enroll people and have them sign up and do a full enrollment, but we're just doing screenings just to give health awareness and education to the masses. And we've had a lot of rich data and research at a de-identified level for just general screenings. And that includes things like blood pressure, which is very highly prevalent, point of care glucose or A1C testing, for example, for diabetes, both of which hypertension and diabetes are very common challenges, especially as we age. The middle part, which I'll get into in more in depth a little bit later, chronic care management, people who, have chronic disease management, they have in-person or remote follow-up visits. They need sometimes referrals to a physician or a specialist, such as a cardiologist, endocrinologist. But biometric monitoring and health questionnaires, very helpful for these patients. So we're able to help monitor because they have a chronic, as you know, it means long-term health condition. So we want to monitor them long-term. And then example here on the right side, acute and subacute care. Here in New York, there is a major health system called Stony Brook. It's one of our partners, for example, and this is an example of, integration into the post-discharge plan, transitioning from hospital to home. So in 2020, we launched a very great program that was able to help monitor patients with specific DRGs to help monitor them as they transition from hospital to home and essentially be alerted very quickly if their blood pressure was uncontrolled, if their weight changes were significant, if they were a CHF patient, for example. And what's really beautiful, as you see in the third bullet point here, virtual consultations by RN and MD. Just using Stony Brook as a wonderful example, we typically have those patients from anywhere from 30 to 60 to 90 days, whether it be coming from the hospital or coming from primary care referral. And it's wonderful because they take their vitals, for example, every day from home, and it automatically transmits via cloud to the portal. And we have nurses and doctors that are able to monitor their patient, but as well as daily vitals, they also do weekly telemedicine virtual visits. And that model, which was developed several years ago, has been very successful. Our patient satisfactions are very high. And of course, we integrate into their PHR EMRs. This one slide just gives you a very quick flavor. I like to segment what we do related to technology and services. Although they're combined, they can be separated, and important to make the distinction. So as you see on the top side, the technology is very simple to use. We often use the term high tech, high touch. So as you see on the picture on the left side, this is an example of a briefcase that is used for holding the equipment. There's a cellular enabled tablet, so we don't have to worry about Wi-Fi or Ethernet or anything related to that. We use high-speed internet connectivity. And then we have Bluetooth medical devices, up to 15 different devices, but the most common, of course, are pulse oximeter, especially blood pressure monitor, as well as the BMI weight scale. And then based on certain projects, like for example, one of our most successful projects is with a Native American community called Shinnecock Indian Nation in East End, Long Island. They have a diabetes related program. So we adjust, and we have glucometer, and specifically during the pandemic, they had asked for a thermometer to be included for body temperature. So we are able to customize the briefcase based on the project or based on the chronic conditions. Outside of the biometric vital signs, I'm on the fourth bullet point. We have pain and mood levels, we have fluid levals, PTI-INR, and a bunch of other inputs. And then what I love about the next bullet point is that, as I mentioned, for most of this, we do a lot of clinical, but equally important, people's social well-being, and that includes things like their transportation, their meals, housing. Those are very important, and it's all connected, as we know, including their behavioral health. And we have a very in-depth, robust health questionnaire feature, which is really where we're able to cross over the lines into the social and behavioral health well-being. And as I mentioned before, on-demand or scheduled virtual visits. And then we have our portal that all the information comes through. So there's the physical hardware, software, as I described, as well as the cloud virtual side of it. And then, what's really important, what we noticed was the unmet need, which any, thing is really successful helps do is, and we found over 10 years ago, which still remains to this day, a lot of times it's not the technology that's missing, it's the services and how you deliver the care, anything but the technology as far as your model. And this is something that my brother Dave and I have really focused a lot on. And with that, for example, we really do focus a lot on services. So, for example, on clinical, we do have daily monitoring offered by a registered nurse provided by our organization. We do very close one-on-one outreach to patients as they're referred to us. We talk to all of our patients by first name. We call them. It's personalized at scale. And then, of course, outbound and inbound shipping with sanitizing. So we do everything from logistics to ship it after we enroll the patients. And of course, once they're done after 30, 60, or 90 days, to retrieve it back, check everything, sanitize it, and prepare for future use. And then, of course, technical support. We have direct line of communication. And that was an essential requirement as we work with different providers because we can't be adding in more time to time that's not there for these providers to be able to deal with a Bluetooth device not transmitting or a tablet that's not turning on, for example. And then, of course, we do a lot of program management oversight and analytics and reporting. At the end of the day, collecting data is great. And if you are able to get the data, it's great. But if you can't prove what you're trying to prove, Dave and I, for example, are data people. We really value the importance of understanding first what metrics are trying to be collected, and then succinctly sharing those informations in precise, actionable reports. So, very quick slide just related to technology, and again, these slides will be available. We have a loaded and locked Android tablet, and it's all secure. So we had a lot of different security requirements as we work with different city, county, state, and federal contracts. So those are some information there. This part I really love where we just talk about health awareness, health activation, and avoiding health emergency events. So as you see with me, just taking a few minutes, these are just wonderful outcomes that we've seen over 10 years now working here and, of course, as an EMT, I get excited for avoiding health emergency events, and I've seen it firsthand and virtually some of these situations. As you see in the first bullet point there was a 64-year-old female with a pulse ox reading of 83%. And in that model, we had hired a community liaison. And long story with this, we just able to get connected to the provider, got the patient to care very quickly and we have that doctor on record that really thanked us for the program and really was testifying to the possible avoidance of, a stroke or other acute medical incident. So that's on the rarer occasions, but I have seen many of these over my years. But really, on the lay person, the everyday person, the top two are really what you can get out of it, right? Using technology in a program like these, but using health awareness, just being more aware. The first step to change, as many of you know, is awareness. And if you don't know what the problem is, or you don't see that um, consequence, so to speak, of not taking your blood pressure reading or eating a lot of foods with high salt, which will retain fluids and increase your body weight, for example, it's hard to make change unless you're aware. And we've seen a lot of patients, hundreds and thousands of patients reach a level of health awareness that they had never seen before the program intervention. And then importantly, if you know what's the issue, you need to be activated to be able to create new routines and make ultimately lifestyle changes. So not only becoming, for example, compliant with your medication regimen and engage in your care, but also taking action to lifestyle changes, which will really make lasting and impressionable long-term changes. This slide here is one of our proudest examples of doing things like what I just mentioned before. It's called the TIPS program. I recommend checking this out. You're able to check this and just be able to see these are some videos that I will share with you, and you can watch it on your own time. We're very proud that we just celebrated 10 years of this program called the TIPS program. It stands for Telehealth Intervention Programs for Seniors. So connected to the Westchester County Department of Senior Programs and Services, we're very proud that we have this program that truly does integrate clinical, social, and soon to be as well behavioral health, working with patients that are over 65 years old. And what's really unique about this program is that it truly does encompass what I had mentioned before as various levels of services to reach this population. So although we've worked a lot with all ages, there is a dire need for helping those that are over 65, especially as they're aging. And similarly, in working in various populations, sadly, without awareness and activation and lifestyle changes, we have seen an increase of patients into their 50s, their 40s, and sadly, sometimes into their 30s with uncontrolled diabetes, uncontrolled hypertension, obesity, etc. We do have a 10-year report with all of our outcomes data. So for those that are on this meeting who are interested in data and outcomes, I'm happy to share that with you. And as I kind of conclude the main part of it here, there are specific CPT medical billing codes that are available. So hopefully we have a few providers that are here in the room or that are able to have ability to bill. And these are just example of CPT medical codes. We have received payment related to grant funding and other types of departmental funding. And as well, over the last couple of years, we have had some of our clients who are physicians that are billable entities to Medicare who utilize these just as an example of medical billing codes that are available. And then the flow chart that you see briefly here on the right side is just a simple flow chart just to show you the flow and step-by-step process that we've been able to develop that's been very helpful. And it's a good amount of money on a regular basis. So as you see on the billing codes, there's roughly $20 to $25 one-time reimbursement, which has been wonderful to help at least cover, shipment costs and educating the patient, whether it be remotely or in the doctor's office. And then this number 2 and 3 that you see below, 99454, is reimbursement on a per patient per month basis. And there are ranges to the reimbursement because it really depends on which insurance they have and also which geographic area they're in. Where we are, we see it a little bit on the higher side of the bracket. And other more remote areas, we see it on the lower end of the bracket in other states. And the bottom code below that is really covering clinical staff or physician or other qualified health professional. And that's very key there because previous codes and other reimbursement models really focused on the doctor that had to be in charge of doing everything. But that is just not realistic in the complexities and busyness of the doctor's time. So they've really adjusted and listened very well to provide not only reimbursement for the setup, which wasn't realized previously, early 2010s time, in my experience, as well as the reimbursement of the equipment was there, but then there wasn't really as much realistic reimbursement that could be feasible for a physician office if it had to be the MD or the DO doing everything. So in our models, we often have nurses who triage the data, and then, of course, on a monthly basis, the physician overviews and approves the activities for those patients. What's really nice about our what we've seen over the last few years and what's been keeping us busy is the introduction of artificial intelligence. And I know that's a buzzword that many of you probably have heard of. And we have added a lot of artificial intelligence as it relates to, as you see on the equipment on the left side over here. So, for example, as we've scaled into thousands and tens of thousands of patients over the last few years across many different states, we needed technology to be able to triage data at a very reliable and efficient and effective way. So examples of artificial intelligence that's possible that we've had experience with in our own system, and I'm sure many other systems as well that you know or are looking at, is the ability to triage data in a non-clinical, non-medical judgmental way. So for the example of Mrs. Smith, who's at home and she's taking her blood pressure, if she has elevated blood pressure, um, in the past without technology, maybe you wouldn't have even known she had high blood pressure because she wasn't showing any physical symptoms. But if you do know that and it's a taken reading, it was pretty it takes a lot of resources for then the workflow of a registered nurse, um, having to pick up the phone and call Mrs. Smith and have a conversation, whether she gets her on the phone or not, remind her to take her medications, because oftentimes it's not taking medications as to a reason why there's uncontrolled reading there. And then if they did take the reading, the medicine to wait 30 minutes and repeat the reading. Those things that are non-clinical judgment, they're not changing the medications, technology has the ability to reinforce standing orders or common practice, as we say, in there. So those are really great. On the other hand, as well, with compliance, which is making sure the patients take the readings, we do have a lot of artificial intelligence built into understanding and analyzing constantly patient data and being able to produce reminders on the tablet and telephonically. And then lastly, what's really innovative about what we've been able to do is that across many, many different programs, it takes, even if it's as easy as pulling up a web portal on your computer, smartphone, or tablet, we're all busy people, and we don't can sometimes easily forget the responsibility to check the portal, for example, to see what's going on. So over the last few years, we've built in artificial intelligence to be able to produce a report that outlines patient health alerts, patient noncompliance, um, in a HIPAA compliant way via email. So we've really enjoyed using that tool on a regular basis to be able to get a snapshot on demand, emailed to you securely, and at whatever time is convenient for you. Most of our clients choose 12 p.m., for example, midday, just to get a sense of how their patients are doing. And it's nice for busy professionals like most of us are, I'm sure. We can easily forget, or it's just another thing that we have to do is to remember to open up the computer and try to find how our patients are doing. Um, so it's really nice to be able to see that. And again, even more artificial intelligence. For example, if Mrs. Smith takes her blood pressure, it's elevated. She follows the directions on the screen to take it again, and it comes down. All of that is annotated so that way they're able to triage and really put resources where they're really needed. So, with that, I wanted to kind of pause and conclude at least the initial part of it. I'm very much interested if you're willing to ask any questions, if you want to share in the chat. I forgot to mention in the beginning a little bit of your background. I'm always interested to hear a little bit of people's backgrounds and how I may be able to tailor and answer any questions that could be helpful. Thank you.
Thank you, Chris. I do see in the chat, Bob has asked, is the initial equipment setup and training done in the patient's home? Can you talk a little bit about that process?
Yeah, thanks, Bob, for that question. I really appreciate it. It's a great question, and it can be done either way. So, for example, some of my clients, they have the education if they want and have the storage to have some equipment ahead of time. Some of our clients will ship them 5 to 10 to 25 kits, and they keep it in the office and they show them right there. They bill and they keep that money that is related to patient education. Um, versus, a lot of other clients who are just want to be really hands off and just let it us do it. When they send us a referral, which is all done electronically, securely, we then call the patient and we ship it as far as the mode of transportation to the home. And ever since the pandemic, we were very much affected, of course, because we used to do home visits every time for every patient. But now, of course, we ship everything in today's world. So all of the education is actually done on our tablets. And it's as easy to do, of course, with paper instructions, front and back, one page. It's not a huge booklet. We keep it as simple as possible. And we have written and short 30 to 60-second videos to show people, for example, blood pressure takes a little bit of training to know how to put it on correctly and everything. So to answer your question, Bob, it could be done in the home or it can be done in the office. It really depends on what the project and the organization wishes to do. That's a great question.
Thank you, Chris. And just, I have a question too, just along those lines with the instructions and getting people set up. Are there options for non-English speaking patients? Are these resources and instructions available in other languages?
Great question. And yes, the quick answer is yes. We have many different languages that are supported, most commonly in our area, Spanish, but also Chinese, and many other languages as well. It's a multilingual support. And also our staff is also multilingual, so we're very competent to that being, our non-clinicians as well as our nurses. So we are fully able to support a variety of different languages. And it's quite common because a lot of the work that we do is serving underserved populations and low income populations of minority groups. So there's many different language requirements, Spanish and Chinese being the most common.
Just another question along those lines, because when I worked in a clinical setting, I used to run into this a lot. Are there options for American Sign Language interpretation? Or would that be something, that the patient would be responsible for having an interpreter on hand?
That's a great question. For any language requirements, if we don't have the right staff live, we do use interpreter services to help us. We haven't had the request of sign language virtually, but I know a couple years ago when I was at a community event, um, we had a patient that required sign language to be able to speak. Um, I was actually lucky. My wife was there next to me, and she actually knows American Sign Language fluently, so she helped me. And so she helped me there when in person. So we haven't had that request too many times, but we're always up for a challenge, and we always like to try to find ways to accommodate specific needs, including vision impairment as well. For a lot of our patients that need some additional assistance, we often have a caregiver, whether it be a paid home health aide, for example, or a family member. And if not, we really find that our services are really needed because if they're living alone, for example, and they need help, we have had so many different situations to try to accommodate. And we really cherish those challenges to be able to help patients. We want to be as inclusive as possible.
Great, thank you. Um, and then Bob, I think you read my mind. So thanks for putting these questions in the chat. So Chris, Bob had some additional questions. He's asking, do you have a list of the EHR systems that you're integrated with and what is the typical process for and cost? If you could go into that for the EHR integration.
Yeah, great question. And just at a high level, not to bore everyone with the technical details, we have integration components and establishments with the major EMR, EHRs, Epic, Cerner, all the different major ones. We just need a little bit of time to tailor the specific integration, and I'm sure Bob is aware of it, to whatever specific needs are. And then the cost really depends, again, really on the specific requirements. If it's just a quick store and forward, that's very much more straightforward. If it's bidirectional communication and it's more intricate, it's a little bit more. But it's just a couple it's not a significant outlay of cost. We just need to be paired with the IT department from the institution and be able to make those connections. So I can go into more specifics, Bob. I recommend if you wanted to connect with me. I'm happy to give more specifics to your specific scenario, but it's hard to give an exact number because everyone has different organizational background needs. Um, so it really depends, but it's not a overly complicated process, and it's not very long process either because there's a lot of health information exchanges and protocols and processes, which HL7 and other types of ways to make those data connection points. And it's very important because we want to make sure for data privacy and security on their end, our end, et cetera, that we're getting the right data for the right patient to the right EHR. Um, so, and what we can do as well, just on that note, until it's fully integrated, a lot of our partners on a monthly basis mass export the data and scan it in as a PDF into the patient charts, whatever thing they have. So some of our clients prefer to do a full integration. Some patient providers prefer just to do, to take 15 minutes out of their day once a month, not even, and just export all and import all into the EMR. So, yeah, good question, Bob.
Thanks, Chris. If anyone else has questions, feel free to either put the questions in the chat and I can read them off or unmute yourselves and ask. Any additional questions?
One thing I wanted to also add, which is very exciting, is that with the reimbursement codes I had mentioned before, there is a requirement as of now for 16 days of readings. So they have loosened up because it used to be closer to 30 days, but then they heard a lot of, feedback from organizations that like we're part of, such as the American Telemedicine Association, is that it's just not realistic. People forget, people are on vacation, etc. So what's really exciting is that proposed for 2026, I know we're like a year away, but soon they're looking to loosen it a little bit further as far as having not a strict 16 days, but be a little bit more flexible and amenable to different things. Um, so it's really nice to see that the payers are really coming around. And it's good evidence about the efficacy that the largest, insurer and payer, being Medicare, is reimbursing for these codes. We really believe that the future is very bright, depending on whether the audience members that were here today, if you are a direct provider who's able to bill, or if you're like some of our, for example, home care clients or other periphery clients who have access to a physician partner, you can create these really interesting models to essentially cover the cost, and perhaps even as proposed with some of our clients, which are doing today, is to actually be a budget positive. So no longer are you going to have to dig into your operating expense to pay for these things, but actually by utilizing the codes, come up with a scalable, sustainable model that is not so reliant only on grant funding, which is what we've had to be a lot for many years. But it's very exciting. It's a very exciting time as we come out of the pandemic into a hybrid world. And if you have any specific questions, I'd be happy to share it here. Or as you see my contact info, I always welcome meeting people and hearing your specific cases, and would be happy to schedule some time with you.
Thank you, Chris. That's good information to have. One other question that I had, I know you mentioned the data and outcomes report. Do you have specific data around, ED and hospital
Yeah.
reduction rates?
Yeah, we do. Over 30% in our TIPS program. I believe 36% is the rate that we've achieved. With our TIPS program, um, we have a lot of data. It's a very long, there is an executive summary, but it is a lengthy report because there's so much data that we have to talk about over 10 years of thousands upon thousands of patients across, I think, up to now 7 or 8 unique states that we've done our work in the TIPS program. It's scaling rapidly right now across the country. I'd recommend if anyone would like to receive a copy of the report, I'm putting my email in the chat as well as you saw it on the contact card. I'm happy to share the report with you so you can see it for yourself and perhaps collaborate one day in the future, or just, whether it be working with us or just learning from us. We're here to make industry changes moving forward because we've seen firsthand, including my parents who have had chronic health conditions, and I've seen telehealth really help them as it relates to diabetes, hypertension, etc. So for me, it's professional, but it's also personal as far as um, the really seeing firsthand what the technology can do for people. So, um, and the good news is that technology is getting more and more affordable, much more accessible, and really scalable. And especially as I conclude, I like to say the best for last about reimbursement is that finally, we've, I think, already proven that there's benefits. It's kind of unanimous nowadays in healthcare. The question is, will this be a resource burden, or will it actually be a positive where, and that's where our company really has tried to be a part of that solution, to be able to provide an organization that could be trustworthy, to be able to take on that heavy lifting of, nursing support, onboarding, technical support, etc. In summary, we pretty much do everything from A to Z. And if clients want to do some of it, all of it, or any thereof mixture, we're here to help support that.
Great, thank you, Chris. Any other questions? Well, Chris's contact information is in the chat, and this presentation again will be shared with the meeting notes. So as he said, you can reach out to him with any additional questions. This was a great presentation, and thank you again, Chris, for sharing your information and your services with us. We're happy to have you today. Just a reminder that within the meeting agenda, I did include some various telehealth resources and webinars that you can visit, as well as some telehealth events that were up and coming. There are still a couple of the Digital Equity Capacity Grant Program webinars coming up on November 21st and December 11th. And we are in process of confirming the dates for the 2025 Telehealth Learning Collaborative. So that schedule will be shared with all of our partners in the near future. If anyone is interested in presenting at a future Telehealth Learning Collaborative, please feel free to reach out to me and we'll discuss that and get you on the calendar. And that is all for today. Chris, was there anything else that you wanted to share with participants?
No, I just wanted to thank everyone for joining. I know everyone has busy schedules, and I appreciate your time. I feel it's important in healthcare to continue to share resources with each other, and I'm pleased to be here. It's an honor, and I encourage you to reach out to me if you have any questions or just want to run anything by me. I'm happy to speak with you. Um, I'm always available, and I hope you continue to think outside the box as it relates to technology and innovation, because as we continue to grow as a healthcare system, there's more and more challenges of provider shortages and challenges. And although it can be tough with technology at times, I've seen it firsthand at times. Patients do really appreciate the access to care and everything. And I've seen it firsthand. So thank you all for your time. I know everyone has busy schedules, and thank you for taking the time. And I know this is supposed to go till 3, but I'm giving you a little extra time of your day back. So thank you so much, Andrea, for having me and inviting me. Thank you, everyone.
Yes. Thank you, Chris, and thank you everyone for participating. I'll be getting out the meeting notes later in the week to everyone, and this is our final learning collaborative for the year. So for those of you who we may not be seeing at other meetings between now and the end of the year, happy holidays, and we will reconvene in January for another learning collaborative, and then just comment, Chris, in the chat, thanking you for your time from Anna from Office of Mental Health. So thank you, everyone. Have a great rest of your day.
Thank you, everyone. Take care.